I'm Graham Turpie. I'm attending the American Society of Hematology meeting in San Diego. There's a lot of interest in the treatment of venous thromboembolism. This has truly been put on a firm scientific footing because of the large number of clinical trials, initially with low molecular weight heparin and more recently with DOAC drugs. One of the questions that clinicians always ask is, can we translate the information from these randomized clinical trials into clinical practice? We've carried out a series of post-authorization studies addressing this question. The most rigorous of these is the phase 4 non-interventional trials, and we completed a study called XALIA in patients who were treated with acute deep vein thrombosis. Initially it was deep vein thrombosis only, but when rivaroxaban was approved for the treatment of pulmonary embolism, we added patients with pulmonary embolism. This was a study in patients with acute DVT or PE in Europe, in Canada and in Israel, where the clinicians made a decision to treat the patients either with rivaroxaban or with standard of care. Standard of care was, of course, low molecular weight heparin or fondaparinux transitioning to a vitamin K antagonist. The clinicians, as I say, made the decision how to treat these patients. When we looked at the data, we found that half of the patients received rivaroxaban, half received standard of care. Now, what we called rivaroxaban patients were those who received rivaroxaban alone or up to 48 hours of parenteral anticoagulation, which was the regimen tested in the clinical trials. However, as might be expected, doctors don't always follow the regimens, and many of them received what we called, many of which we called early switchers, received parenteral anticoagulation for longer than 48 hours, sometimes up to 14 days, before transitioning to rivaroxaban. These were analysed separately, and with a sensitivity analysis, it did not influence the outcome of the study. It is interesting that doctors did choose to treat the lower risk patients with rivaroxaban and the higher risk patients with standard of care. For example, the age of the rivaroxaban patients was substantially lower than those who received standard of care. Many fewer had abnormal renal function in comparison to standard of care, and most difference of all was in patients who had cancer-associated thrombosis, where the majority of patients received the standard of care. Because the patients were quite different, it would not be appropriate to do a direct comparison of the crude rates. So we did what was called a propensity adjustment of the populations, and what we found was that there was no difference in the risk of major bleeding, recurrent VTE or mortality in the patients receiving rivaroxaban in comparison to the standard of care. But what we did find was a statistically significant reduction in the duration of hospitalization in those receiving rivaroxaban, which is, of course, is a very important observation with respect to healthcare costs. At the American Society of Hematology, we presented a new study of the XALIA, which was a sub-study in patients who had active cancer. 587 of the 5,000 patients had active cancer, and it is interesting that once again the doctors chose to treat them in a different way. Some patients received low molecular weight heparin alone, some received rivaroxaban, some standard of care, and we also had some early switchers. In addition, we had a group that we called miscellaneous. These were patients who received fondaparinux alone or vitamin K antagonists alone. By far the greatest proportion received low molecular weight heparin, which of course is the recommended regimen for cancer-associated thrombosis. 38% of the patients received low molecular weight heparin. However, 24% of the patients received rivaroxaban. Now, it is interesting, when we look at the outcomes, you can see that by far the worst outcomes are in the patients who received low molecular weight heparin with a mortality rate of 26.7. When we look at the outcomes in the patients receiving rivaroxaban, they had the lowest mortality at 4.8 and also the lowest rates of recurrent venous thromboembolism. Why is this so? Remember, the clinicians made the decision how to treat the patients, and it seems that they chose to treat the more advanced cancer patients with the standard of care and reserved the rivaroxaban for those who are less sick. That is a very interesting observation, and I think that from a personal point of view, I think that we should consider how we treat patients with cancer associated thrombosis. Do remember that the clinical trials that demonstrated low molecular weight heparin showed a marginal benefit but no mortality benefit. And it seems to me that it might be appropriate to consider giving the patients with cancer-associated thrombosis with a limited life expectancy a much simpler regimen such as an oral anticoagulant without monitoring. When we look at the data, however, we have no randomized clinical trial data of rivaroxaban against low molecular weight heparin, and there's an ongoing program called Callisto addressing this question. To summarize then, the sub-study of XALIA in cancer-associated thrombosis demonstrated that treating physicians most commonly chose to prescribe low molecular weight heparin. That is consistent with current treatment guidelines. However, they did choose to treat a substantial number, a quarter of them, with rivaroxaban. The primary outcome was lower in those patients receiving rivaroxaban than in the low molecular weight heparin cohort, but this I suspect is due to the fact that the low molecular weight heparin patients were those with most advanced cancer. The findings, however, suggest that rivaroxaban could be considered as a viable treatment in patients with cancer-associated thrombosis as an alternative to low molecular weight heparin. Well, thank you very much indeed for your attention, and enjoy the rest of the meeting.